Let's talk about BIPAP, a long overdue presentation. What is it good for, and how and why do we use it? In order to understand that, I think it's helpful if we take you backward to the origins of BIPAP, and then maybe go through a case study where we've used it, about settings and possibly troubleshooting. The BIPAP presentation will be in several parts. The machine you're looking at here represents the latest advancement in non-invasive ventilation. I choose to call it BIPAP rather than non-invasive ventilation because that's the term we use in our hospital and that's the equipment that we use. Here's another picture of it. I'm not exactly sure where this picture came from, but I think I'm just the same. Now, before we had the wonderful Vision BIPAP, the predecessor would be the STD-20 and then later the STD-30. The picture you're looking at now is of the STD-30. These machines, although not as easy to use as the Vision, are still very commonly used. My preference would be a Vision BIPAP, and I would probably pick this one second. Let's talk about the origins of BIPAP a little bit. This machine, the Respironics STD system, goes back to the early 90s. Before that, we used CPAP with some good success. You might say that BIPAP is the offspring of CPAP, CPAP mask, which came out in the early 80s, and pressure support, which came out later. Wide acceptance of BIPAP probably comes out a decade later. Since CPAP predates BIPAP, let's talk about that a little bit. But let me warn you, CPAP has several distinct yet related definitions, or meanings, you might say. For example, continuous positive airway pressure is used for sleep apnea to overcome airway obstruction, like you see in the cartoon. Let me clarify upper airway obstruction. The word CPAP is also used to mean a mode of ventilation where a patient is breathing spontaneously. It may literally be CPAP in that you have continuous positive airway pressure, or it may not be. And finally, the meaning that's most relevant here is the meaning of CPAP as an adjunct to improve gas exchange in individuals with refractory hypoxemia. I'll explain that a little more. Let's look at the kind of case that might actually necessitate CPAP or BIPAP. To set it up, everybody recognizes this. This is one of 300 million alveoli in the lung, and this is the corresponding capillary bed for that alveoli. I'm going to make some changes to it. Let's take a patient who is in heart failure. And what happens in heart failure is the pressure inside the left heart builds so high that fluid is entering the left heart quicker than it can be pumped out. The muscle's in failure, and what happens is fluid backs up into the vascular system of the lungs. And so the vascular system becomes engorged with fluid, with hydrostatic pressure and fluid pushing outward. Now, if you expand, you see my little arrows where I'm showing the vascular system pushing outward. What that does when all the vascular system of the lungs do this is it takes away from the airspace in the lung. So if you enlarge the capillary bed, something has to give, and in this case we'll say that the alveoli then, remember the alveoli are all interconnected with one another, the alveoli then become shrunken from fluid pressure. Fluid also goes into the interstitial space and puts pressure on the alveoli from the outside. Now, oxygen is very sensitive to the surface area for gas exchange in the lung. And if you start compressing the alveoli, let's do it some more. Let's put even more fluid in there, and the pulmonary edema is actually worse. So now our alveoli is literally smashed from the weight of the fluid pressure inside the alveoli. And our vascular system is literally engorged with fluid pressing inward from all directions. Now what's going to happen here is a loss of surface area for gas exchange in this alveoli. Well, how's the patient going to look when they come in? The patient will suffer with hypoxemia, have low saturations and low PO2. The heart will try to compensate by beating faster, and the patient probably be tachypnic and have increased work of breathing. Now, this stress puts a compromise. The patient starts to work harder to breathe. It starts to compromise the muscles. What do we do for this patient? They come in hypoxic, and so we put them on oxygen. But since all the alveoli are affected negatively by this increase of fluid in the vascular system, the addition of the oxygen does very little good. In fact, what do we use as our definition for refractory hypoxemia? When we put a patient on more than, say, 50% and their PO2 doesn't rise at least to the 60s? Well, this might be a time to try something else. Years ago, positive pressure was applied with a system like this. You see, this is a pressure mask that can fit over the patient's mouth and nose. There are two one-way valves on it. One of the one-way valve is an inlet. It allows a gas flow of greater than 30, 40 liters per minute, enough to meet the patient's inspiratory demand, but they couldn't exhale. They'd exhale through another one-way valve, which was then connected spring-loaded PEEP valve. And so the patient would exhale into this device, which you could dial in a level of CPAP or PEEP pressure from 0 to this particular one from 0 to 10. You could dial it in, and so the patient would exhale against a diaphragm which was had a spring behind it. And so by changing the tension on the spring, you were able to create a positive pressure with which the patient had to exhale against. All that was required to run the CPAP setup was an oxygen source that was capable of producing an output of greater than 30 liters a minute, the pressurized mask, and a harness that could hold the mask to the patient's mouth and nose, and finally this PEEP valve. And it was a very simple setup, and it worked very. It's quite a struggle to breathe when your alveoli look like this, when they're compressed by fluid in the vascular system pressing on the alveoli. Many alveoli are collapsed by fluid pressure and have to be re-recruited by the positive pressure. Fluid also leaks across into the alveoli, and some of that fluid washes that surfactant up, so you get that foamy. Remember, surfactant is a soap, and so you get that foamy, pink, frothy secretions from some of that fluid in the interstitial space and that fluid pressure washing up through the alveoli, small amounts of it. So anyway, let's put the patient on the system that I just described with a positive pressure mask and a breathing against a PEEP valve, so the patient maintains a positive pressure during the inspiratory cycle, during inspiration and expiration. So let's put +5 of CPAP. What the +5 of CPAP does is it restores the size of the alveoli and thereby increasing gas exchange. And it can be dramatic when you put a patient in refractory hypoxemia on CPAP. It can make a dramatic difference. A person that was barely able to maintain a oxygen sat of 90% on 100% non-rebreather, suddenly on 5 or 10 of CPAP, that patient can be weaned down to a low FiO2 with the addition of the 5 CPAP. So it makes a dramatic difference. And so it was discovered that this worked very well. However, there's a downside.